Hello, everybody. I am taking you to Darby, your Darby and Walsh book, Chapter 2. We talked about the human needs theory, like in the beginning of the semester, week 1 or 2. As we start to go into Wilkins' chapters for the dental hygiene diagnosis and dental hygiene care planning, she does a great job initially setting that up, but we're going to combine what Darby has in terms of when we start to write our dental hygiene diagnoses. So we're going to try to keep it relatively simple this semester and get into a lot more details in our next semester course. So Human Needs Theory, Chapter 2. This is a video that I actually downloaded from a news station, and the reason why I put this in is that this was a feature about how drinks, soda, destroys teeth. And in school, it's information for teachers. Now, teachers do receive oral health packages, educational packages every year, usually before the month of February for National Children's Dental Health Month. And a lot of times they really don't know what to do with this information. And that is why they often welcome dental hygienists or other dental professionals to come in and talk to their students about caring for their mouth and overall health. And of course, different grade levels, you could address different things. This one happens to be soda. And there's a little video about soda consumption and what it has done to the enamel surfaces of the teeth. Oftentimes we call that Mountain Dew mouth. Sometimes we just look in the mouth and we can see that. But see, people don't know what they don't know. So that is a deficit. That's a human needs deficit of knowledge. Now you can know something about it and then not do anything. That would be a deficit of responsibility. So we have our basic 8 human needs, and then we start to apply it based on what a patient presents to us and what they tell us. And our interventions and what we implement for this patient in our ADPI process is going to be decided by the information that we gather from a patient. So the primary role for the dental hygienist is to motivate and empower patients to adopt and maintain a positive oral health behaviors for themselves. Key word here is motivate, and the days of telling a patient what they have to do are gone. We really have to do motivational interviewing, and Wilkins gets into that a little bit. And also have a great article about motivational interviewing from our Dimensions magazine as well, and I'll post that in Blackboard. We want to involve the patient actively in their process of care. We need to show them their x-rays. We need to show them and discuss our findings with them. We need to make it all about them. We have to use all of the subjective and objective data that we collect from the medical, dental, and social history. We collect our data from our clinical oral exam, and that would be extraoral and intraoral findings, and any other data that we collect during the assessment. Oftentimes, patients reveal things as you're going through an exam, and they remember things and it triggers them, and then they'll give you more information. If that were to happen, you need to add that into your dental and social history data. There's collaboration with the patient. Darby calls the patient client, so you'll see it written as client and or patient to help them establish their goals. Now, their goals must be realistic. You don't want to hand a patient 5 different extra items or tools for them to use to try to care for their mouth. That will be very overwhelming. They need to see the value in what you're having them do or value for themselves, and it needs to be easy for them to use. They have to have the ability to do so. You don't want to sit there and show a person how to floss their teeth, holding the floss on their fingers like we will be teaching you if they have rheumatoid arthritis and their hands are not able to do that. So they have to have the ability to be able to perform any kind of intervention that you might have. And when they are involved in setting the goals, then that's going to help them be successful in starting them and or maybe for a lifelong. People try things and then we we're human. We do things for a while and then we lapse back into our old habits. So it's an ongoing motivational piece that we do. The human needs theory is pretty much based off Maslow's hierarchy of needs. We have to bring that in. A person is not going to be thinking about themselves in terms of maybe their overall, how they look, and maybe their health unless their basic physiological needs are being met. Do they have a house? Do they have food to eat? It has to be their basic needs have to be met. And then they climb up to safety, security. Then they have a feeling of belonging, self esteem. And then self actualization is at the top of the pyramid where they're then able to listen to what you might have to say. There's also something called the learning ladder. Now, this is from the former edition of Wilkins, and there are steps that are involved for learning, and it's, they have to climb the rungs of the ladder, if you will. They're unaware. They can't do what they don't know. People don't know what they don't know. That we have to make them aware of their current setting and where they are, and then we have to help them climb that ladder of self involvement and action and maybe developing a habit. So it is a process. It's multiple things we have to take into consideration regarding the individual, and that is what's so wonderful about the human needs theory is it keeps us from judging a person. We need to know where they're coming from. There's the dental hygiene paradigm of the concepts are explained here. So you have your human needs theory. You have to bring these four concepts together to make it happen. So you have your client or your patient. You have the environment is huge. In terms of their physical environment, maybe their cultural environment, their family environment. What are they able to do? And their overall health and their oral health. We bring that in, and then we have our dental hygiene actions. So all of these four items need to be working together, are in place of understanding in order to meet the needs. This is the slide of a page that I gave you in the beginning of the semester. So this gives you examples of the 8 human needs. Protection from health risks. That can be from a variety of that can come from many different aspects, whether it's dental or medical, like needing prophylactic antibiotics before they are seen for their dental problem. Or it could be high blood pressure. It could be uncontrolled diabetes. It could be other types of uh, medical conditions that are not considered within the normal limits. Freedom from fear and stress. Now, we do know anxiety is very great still in the dental office, and so we need to address that. We need to recognize it, and we need to address that. Freedom from pain. Pain's always going to come first. We need to always address the person's concerns. Wholesome facial image. If they're telling you things like they have bad breath or they don't like the way their teeth look or their tissue bleeds, those are deficits in wholesome facial images. We have the skin and mucous membrane integrity. So if you're finding any kinds of lesions or gingivitis or chronic or acute periodontal disease, clinical attachment loss. So now they're deficit in that integrity of what they might have started out with when they were human. And of course, biologically sound and functional dentition. That can be tooth decay. It could be demineralization. We'd be looking at maybe their habits of their food intake and maybe their soda drinking could be a possibility. And so you might say something to the effect of a dental hygiene diagnostic statement here could be that their deficit in biologically sound and functional dentition related to a karyogenic diet as evidenced by patient drinks 3 Mountain Dews a day, snacks throughout the day with crackers and such. In other words, you are trying to identify a problem that a patient has. You have to relate it to identify it as a deficit and the evidence. So whatever your patient presents that you see, whether it's gingivitis, tooth decay, other oral lesions, whatever it is, it has to relate to something. You have to investigate why is it the way it is. And then also conceptualization and problem solving. So, we have to help them um, understand the process and the rationale for what we're telling them so that they can proceed and maybe possibly change some behaviors if that's what's needed. And then there's the responsibility for oral health. So, they know about plaque and calculus, but they just don't do it. They don't floss. That would be an example of that. That would be deficit in responsibility for oral health related to um, patients not flossing or inadequate biofilm removal as evidenced by, and then you would state maybe their plaque score or any statements they may have made. So when we get going on our dental hygiene diagnostic, you can see that we have the unmet human need, and it's due to or related to, to the etiology, what caused it, as evidenced by, and so your signs and your symptoms would be there. You would create some goals with your patient, and you would keep them simple and realistic, and then you would create some interventions, very simple interventions to get them to improve whatever it is that needs to be improved. And then evaluate. We always have to find out, did the patient meet the goals, their goals? Did their plaque score go down? Are they now flossing? Are they now using the brush properly? Are they using any interdental aids? So that is ADPI. We assess, we dental hygiene diagnose, we plan, we implement, and we evaluate. That is the process of care. So this is just talking about those various concepts of what a client is: a biological, psychological, spiritual, cultural, and intellectual human being who is integrated, organized, whole, and whose behavior is motivated by human need fulfillment. We're all going to do things when we're ready to do things. It can be an individual, a family, or a group, depending upon who it is that you are addressing. If you're one on one with a patient, it would be an individual. If you're doing family counseling, it would be a family. Or if you're speaking to a group of students in a school, it would be a group. And it's viewed as having 8 human needs, especially related to dental hygiene care. So if you're speaking to a group, every single individual is going to be different. They might have a different uh, area to address. This is a basic circle of showing that there's your client, and then they have unsatisfied human needs. We sometimes refer to those as met or unmet. So we need to address the unmet needs, motivational behavior, get that human need fulfillment where it's wholesomeness. And that is a circle, pretty much like the process of care, where we're taking it from the beginning to the circle, and then we have to continue on to maintain that. Or new things can develop, which would change what you would do. The environment is going to influence the manner, mode, and level of human need fulfillment for the person, family, and community. It affects the client and the dental hygienist, and both influence the environment. So you're going to be influenced by your environment and what you say, and your client or your patient's going to be affected by their own environment. So it includes society, climate, geography, politics, economics, education, socio-ethno-cultural factors. That's very huge. That is understanding cultural diversity. Their significant others. Some people are very driven by what their spouse might say. We're not going to do that treatment. We can't afford it. Those kinds of issues come into play. Family, community, the state, the nation, and the world. Like, what is going on? And you got a little taste of the political side of it when we went today at the Capitol. How do we reach people? Some people do not have access to care. Lots of levels and many layers. This is just a diagram showing you, how from the patient or the client is in the center, and how the client is affected by all of those environmental factors as it spreads out, as we all are. We talk about health and oral health. We know that they are connected. It's exciting that the mouth is finally part of the body, and that we do know that it's a continuum. You know, we can go from illness to health, we can go from health to illness, we can go from health to serious illness and get it to a point where it's decreased or diminished, getting back to health, but sometimes you never get back to health. So we need to understand that it's a continuum. It flows. There's an ebb and a flow to our health. And that's going to mean that we need to adjust and accommodate those changes. It's never just the same. You often hear us say there's no cookie cutter way to address a person oral health needs. Yes, everyone needs to brush and floss, but those are the basic bare minimum. And then we have to take the individual needs of that person and create a model that works for them where they are on the continuum of health. So, dental hygiene actions are behaviors of the dental hygienist aimed at assisting clients in meeting their 8 human needs related to optimal oral wellness and quality of life throughout the life cycle. It's a continuum. Dental hygiene actions take into account the client and environmental factors as the individual's age, gender, roles, lifestyle, culture, attitudes, health beliefs, climate, and level of knowledge. Where are they now? Are they evolving? Are they changing? Are you evolving? Are you staying current? So we work together. It is working together and collaborating for ultimate optimal health. So there's the dental hygiene process. We are assessing. We use all of the subjective and objective data that we collect, medical history, dental, social history, all of our findings as we collect the data for the dental charting and the periodontal evaluation, as we take our radiographs and we look at where they are in terms of overall health for bone level or caries. We create a dental hygiene diagnosis. We create a dental hygiene diagnosis using the 8 human needs to address the individual needs of that patient. That's where we're going to get our plan for. Once we have a plan and we present it to our patient, the patient must have informed consent. They must understand the plan. They must agree to the plan. Only then can you implement your plan. So then you implement your plan, and then you must evaluate the outcomes of that plan. And the cycle starts all over again. So the dental hygiene process, here it is in terms of generic definitions and the human needs conceptual model. So yes, we collect and analyze the data. We are identifying oral health problems that could be related to their systemic health and their own habits. But we are going to utilize the 8 human needs, and of those being met or unmet, to help us from keeping an open mind with our patient and not being judgmental. Remember, we are seeking to help this individual. We're going to use critical decision-making skills. You need to assimilate all that information you took and critically think in identifying those 8 human needs so that you can write your dental hygiene diagnostic statements. And you know, when there's a problem that's presented, there is evidence. The evidence is the signs and the symptoms, the signs that you see: red, inflamed, bleeding gums. Symptoms: patient says, my breath is bad. Those kinds of information are all brought into it. And we have to have realistic goals and treatment strategies. And you know, we can give that patient some deadlines. So do you think that is your goal? Do you think that is something that you can achieve when you come back? Let them make that decision. And then we carry out our planned interventions, and we're targeted on the causes of the unmet needs. We have to evaluate the goals. Were they achieved? Were they met completely? Were they partially met? Or were they unmet? You don't just say, yes, they were met, no, they were not. Maybe the patient is trying. Maybe you need to modify what you implemented the last time. So that partially met is very critical because the ongoing process means that you are looking at all the data, everything your patient tells you, and you may need to modify it as you go along. Here's that learning ladder again, and I just put in the steps of it. So, we all start at the lower rung of the ladder, and we have to climb to success. Now, this is no longer in the 12th edition of Wilkin. She presents it a little bit differently, very much into the motivational interviewing and understanding where a person is in terms of the value of what they are being presented with and what they're able to do. But unaware, they don't know. People don't know what they don't know. They may become aware, they might have good knowledge of the scientific facts, but they don't apply it for personal action. They're not going to do it unless they're ready to do it. And it's going to depend upon how and if they were motivated. It's got to be self-interest. It's got to be about me. It's all about them. It doesn't really help to show them just pictures of where they can go, even though you're creating your flip chart. Those are pictures, but you're going to take your pictures and you're going to tailor it to their findings. Tell them what their numbers are. Show them where their bone level is on their x-rays. Make it about them. Involve them so they can apply that new knowledge, so they can take action and begin to make a change. And then finally, maybe they'll develop a habit. But remember, it's a process. It doesn't always happen the first time you tell a patient something. And trust me, you will hear a patient say, no one ever told me that. Okay, so that is something that you have to listen to with a grain of salt. They may have been told, but they weren't ready to listen. So when a person says that, that's the first sign that they might be ready to listen, because I'm sure they were told to brush their teeth before or to floss their teeth before. Or maybe it wasn't explained to them, or a rationale wasn't given why, and so they didn't listen. We know that we can explain and modify what we include in patient care. We do have to take medical conditions into consideration, and we have to acknowledge those and understand that they have an impact on oral health. An example of that would be uncontrolled diabetes. So that can lead to issues in the mouth and trying to control possibly periodontal flare-ups. You want to reassure the patient that you're going to take care of them. If they've had a negative experience in the past, you can assure them that you will take the steps so that they are cared for in a comfortable and a safe environment. That's one of the great reasons why we do local anesthesia. We don't have to rely on the dentist coming in that might be rushed to give local. You can take your time and use a numbing agent and talk to your patient in a soothing tone to make that experience a little bit more easy and a little more comfortable. You want to listen to what they say. Listen with active listening and respond back to them, making sure that you're understanding what they are saying. You want to present the rationale and some detail of methods for what you're recommending to prevent and or manage, control oral diseases or treat them. And you need to offer choices for self-care. People like to use different things. So you give them one thing, they leave, they try it, they come back for the next appointment. How did that go? You ask them. They say I didn't really like it. I was uncomfortable. You say okay, and you try something else, and you record that new intervention. You're always encouraging your patients, even if it's the smallest gain. Always present what's positive first, and then tell them how they can modify it. It will shut a person down if you say, well, oh no, that you're not doing that the right way. Let me show you how to do that. They're not going to listen. So throw them something positive first. There's, of course, always we have to think of the legal, ethical, and safety issues. We have to discuss all procedures. We have to explain procedures in a way that they understand. We have to obtain their consent, informed consent. If they choose not to do any treatment we recommend, then they have to do informed refusal, which is not on here, but they would need to do that. And then you want to encourage their participation in the plan. You can present it, but they have to do it. So you are a team. You may need to postpone an appointment because maybe they have a medical condition, or you might need to do a medical consultation to make sure anything that you do is safe for them. And they might have infectious lesions like herpes on their lips that might prevent you from doing treatment that day. And that would all be dictated by how old it was and if it was at risk to spread or if it was multiple lesions. That's just one example of why you might postpone treatment. And you're going to address any medical contraindications before performing any instrumentation. So that would be a medical consultation. If you feel like they might need some pre-medication prior to using a periodontal probe or an explorer, causing bleeding or where bacteria can get into the blood system. So that's a little glimpse of what we will be doing. And please let me know if you have any questions, and we will discuss it in class. Thank you.